David, I just finished going over an Imperial College study that described two health policy alternatives. One they called suppression, and the other they called mitigation. Suppression is quarantine and social isolation and focused on reducing the rate of transmission of the COVID-19 virus. By isolating people, they reduce exposures and they reduce the rate of infection, even though they admit that ultimately 80% of the population is still going to get infected. That's suppression. Mitigation is different. Mitigation attempts to calibrate the rate of infection so that it matches the available medical resources that will be required, recognizing, however, that that's an impossibly precise task, that more people will die by allowing the rate of infection to increase. However, more people will be exposed, develop infections, and become immune. The mitigation strategy attempts to slow the peak a little bit, but it recognizes the advantages of spreading immunity. Well, it also recognizes that it will kill more people in the short run. The suppression alternative attempts to spread it out more slowly by reducing the rate of transmission, but that also means that there's less immunity built up in the population. This is the two alternatives that were described in this Imperial College study. What are your reactions?
The Anglo world has lost its mind.
Restore the Anglo world to sanity.
Well, first off, you brought up this thing that circulated and was abandoned because it was insane, unethical idea that letting the virus spread builds up some kind of immunity in the short run. That's just utter nonsense and unethical nonsense. So just clearing that up, immunity is a program, happens through a program of vaccination. Once the disease is established as a regular occurrence, whatever its time course over the seasons is, we have vaccines and update the vaccines as the virus mutates, then we want to build up some immunity in the population that spreads to people who haven't been vaccinated. The idea that this happens just because of exposure to the disease is crazy talk.
Hang on a second on your crazy talk,
and it
Dr.
was quickly
Woods.
Called out by many, many people. I wrote a satire as soon as
I haven't heard it called out. This is the first time I've heard it called the crazy talk. What I've heard, never mind what I've heard, what I experienced was before there was a chickenpox vaccine, my parents deliberately exposed me to chickenpox. And that was so I would have it when I was a child rather than have it while I was an adult when it's more dangerous, as well as expose them and boost their own immune system to ensure they had antibodies against shingles, which is a much more painful and dangerous disease. Why is it crazy talk?
Essentially your parents were carrying out a program of vaccination. The same point holds.
I would call it inoculation. Yes.
Yeah, inoculation. And with a non-dangerous disease relative to something else. While shingles is painful and can have long-term consequences, it's rarely fatal. So not remotely comparable. Not for a novel virus spreading through the population of the globe. But to me, the pointing out, and The Guardian published some things pretty quickly, and then there's been a series of things talking about it. This just points out how easily when confronting a novel situation, people start to import a variety of folk models and half-baked things. Well, I heard this, or it works in this other situation, so let's apply it here. They're under pressure. They don't have enough knowledge. And instead, this is, unfortunately, in the Anglo-American world, created a vacuum at the top. Now, we have to step back and talk through a few things that relate back to why resilience engineering highlights a bunch of the things we need to do. And let's focus on some more subtle problems with the Imperial College report. posing right off the bat, you see this idea of let's categorize. It's either this or this. We can do one or we can do the other. That's completely misframing the situation. And the development in disaster resilience and resilience engineering tells us about what's really important here. The key idea is a rate. How we have to match two rates. It's about rate, not about numbers, it's about rate. So there is a rate at which the infection spreads. There is a rate at which infected people need hospitalization. There is a rate at which hospitalized people need ICU care and ventilators and other scarce resources. And so what we're trying to do is match that rate of challenge in terms of patient needs as the virus spreads to the deployment, mobilization, and generation of response capability. We build response capability, and we want to build a readiness to respond in advance of the advancing rate of patient needs for care. Now, we have some estimated numbers on some of these rates, right? Roughly 20% of the population requires hospitalization. Roughly 5 to 7% require intensive care sorts of care. Of those, a percentage require the most aggressive techniques and therefore the equipment and specialists within the intensive care. The question is, what's our deployable capability? So let me give you an example that we've been tracking right now where I live. As the rate is ready to explode. Now, first off is, right, this is a rate, and we get some data about what's the infections popping up in our area. So we'll talk about where I live, the state of Ohio. And as things pop up, we get some testing results, and testing is not widespread. It's a limited resource right now. It's been delayed in happening. And so we identify less than 100 active cases. But there is a difference between the ones we know about through testing or people showing up at the hospital, all right, and the rate of prevalence of it that's growing in the population at large. And that difference is 1 to 2 orders of magnitude from the data available across the world so far, from places that have already experienced the rate increase and had to develop and deploy a readiness to respond to compensate for that for patients. 1 to 2 orders of magnitude. So that under 100 actually represents 1,000 to 10,000 cases in the population. So what does Ohio do? Well, they start actually in a local way. They start following what we've laid out for resilience in avoiding brittleness, keeping up with a developing disaster by assessing their deployable capability. So an example here is one hospital might have currently be at 75% of their ICU capability. Just happens to be, right, these ICUs tend to run fairly loaded. They happen to be at 75%. Another one might be at 80. Another one might be at 72. The point is they have some deployable capability to handle more patients. Then we start to see them carry out mobilization tactics. And they start thinking about, how can I expand the number of ICU beds outside of the ICU? Well, we can do some things. What's the critical equipment? Ventilators. Where can we get ventilators? We can get them from operating rooms, but only if we reduce the schedule of operations. Right? So Ohio has come up with criteria for what surgeries should go forward that are non-COVID-19. Remember, COVID-19 is a coming explosion in Ohio. On the other, rate's going to increase. There's going to be a surge. On the other hand, there is still the existing flow of patients who have critical needs, be they from cancer, heart problems, heart attacks, car accidents, etc., who require intervention and care. So what part of that normal load on ICUs and operating rooms can be deferred, freeing up personnel, freeing up protective gear, freeing up specialized equipment, freeing up specialists in order to care for the COVID-19 patients. So now which ones? You have to come up with criteria, you have to say and adopt them, in this case, regionally, the state, in a uniform basis, while still providing some flexibility for doctors and patients in terms of what's needed where. So they're mobilizing in a variety of ways capabilities. Another way would be ways to move non-COVID-19 patients to other parts of the hospital or other facilities and adjust the kinds of care that we provide to a place that's outside the normal ICU, or stand up ICU for COVID-19. Why do you need to separate these? Because of the contamination issues. If your trains of patients start to interact, you get transmission with already sick people who are most at risk from the new disease.
So at this stage, you're describing Mobilize. Do I have that correct?
Yeah, so we've had deploy, mobilize, and now generate.
Yep.
Right? That's the sequence we've written about since 2006 of how do you build the readiness to respond as one of the 4 basic capabilities for a resilient response, right? And we'll talk about some others in a second. But so what we're seeing right now, and was just discussed today, I was just monitoring some of the announcements, is a variety of ways that people are starting to generate capability. So for example, because of economics, some hospitals have closed. Well, those could be reopened. China built a new hospital. We can reopen ones to take non-COVID-19 patients or as isolation, so we don't have this transmission between people needing medical care in hospitals. We can move non-COVID-19 patients to other facilities. Hotels are fairly empty. So as people care gets requires less care as in a recovery process, we could start standing up hotels. And so there's an exploration of what hotel space could we take advantage of? What would we have to do to prepare it? Notice there's a time lag. If we don't, this is going to set up the anticipation one. If we don't anticipate it and set this up in advance of need, when we saturate the capability of the deployable capable of the ICU, where are we going to move things? And if we do it in an ad hoc, reactive way in the middle of the crunch, we're not likely to do it as well, versus anticipating the need to expand our capability to respond. So we generate. There's some other things going on right now. Another good one is there are some hospitals that operate under standard conditions, under standard rules and authorizations. That means, for example, they have a maximum of 25 occupied beds for maximum of 96 hours. Well, the standard rules don't apply in a context of an epidemic.
We can move those constraints. Yeah.
You remove those constraints. That requires a relaxation, and that authorization to relax comes from a different layer, a different level of the society and organization. So in our case, a federal level authorizes the relaxation, so they can now think about expanding the capability to handle patients of some of these other hospital facilities. Now, let's take another example that just came out today here in Columbus, which is OSU hospitals, very quietly had stood up testing, drive-through testing. Oh, wait a minute, where did this come from? They just announced they'd been doing this today as part of the process. So what's this? This is the intake problem. Now, how do you organize the intake of patients? Who's really sick with COVID-19? Who's got some other condition? How do you track things? And how do you protect the healthcare personnel in this process? And here we see a bunch of generation and innovation going on that requires initiative, coordination, and communication horizontally across the critical functional units. The functional units are emergency medicine and intensive care. So what are we seeing? We're seeing what we've described previously, back again a decade at least, of horizontal emergent cooperation, where people repurpose normal lines or channels of communication so that ICU heads are sharing information. ICUs that have already been slammed with critically ill patients from COVID-19 are sharing information with other ones through the informal and semi-formal and formal networks horizontally among leaders of ICUs and emergency medicine departments. And they're innovating and standing up things, that initiative and innovation to handle things. So what's happening? The news today, both here and in Texas, was, oh, tents are appearing outside hospitals. Why are tents appearing? That becomes an intake unit where you can do evaluation without bringing them in and potentially contaminating and needing to clean. So you start disinfect the areas. You start setting up one spot where people who may have the disease come in to be assessed. You can concentrate your personnel, the protective gear, the cleaning process, to quickly evaluate those people as a kind of early triage area. How sick are they? What do they have? Should they just stay home because they're at low risk of severe things? Give them instructions of when they should come back. Should things worsen? Who do they bring in? Who's not real? Who doesn't have it but has something else that requires treatment or can be sent home? So that decision-making point is being innovated. And I got an email example of this from Texas where Baylor had set this up and was sharing it with other people across other hospital systems across Texas. And people were going, great idea. We're all, this is a great thing for us to adopt. Now, what we see is that innovation and sharing and emerging horizontally, and it's an empirical finding, but it also relates to the way that people adapt to create resilience in systems. And how do we support that? And we can support that in a variety of ways. Recognize it. We can facilitate it, right, by spreading it. We can evaluate it, right? It may be an interesting innovation that works in one setting, but to make it a general approach, we need to corroborate it, test it, modify it. So we can do some things to cross-check and then disseminate. And the most important thing is don't block it. The report from Seattle was a research physician had a protocol when it involved testing who was recognizing community transmission early in the outbreak in the Seattle area. She went ahead and tested people outside her research protocol. No, the authorities told her. So she kind of stopped and then tested some more and is coming back going, there is community transmission.
Yeah.
We need to wrap up. I'm ready to go. Let's do this. Again, she was stopped. Right. And so the opportunity to surveil, to monitor, to understand and build that anticipatory capability was lost. That cost them, I don't know how many days, right, in building up their readiness to respond rather than getting a surge and slammed, overloaded, saturated. Now, we have in resilience engineering this notion that a lot of this, right, these are fundamental notions of you want to understand resilience, understand how people anticipate and respond, right, to avoid the risk of saturation, to create the capacity for maneuver. So all these things I've been talking about are just that. People in various roles at levels themselves and coordinating with others. I describe coordination across a state of different organizations and entities at the state. Something that we've described often as when that coordination is good and well synchronized helps a region respond effectively to large scale disasters. We see that coordination going on at an ICU leadership and emergency department leadership level across different functional layer, right? Again, these are things that we've noticed. What's different about this is happening at a continental and intercontinental scale, right? Of who's sharing information and how is this being developed. Now, what this sets up is these rates, and can we match these rates, sets up the anticipation paradox that is still plaguing parts of the world, especially the US, where we see this until we get until the epidemic numbers are high, back to the category that we started with. The category, how many counts, how big is it? Oh, it's big, we've got lots of patients. If you waited that long, it's too late. You're stale, you're too slow. You have to anticipate and pick up and look for and recognize the early signals that this is developing, right? Back to this thing, one analysis that tends to show that if the counted cases of infection are at one level, the actual in the population is a rate coming at you, and that rate coming at you is at least an order of magnitude bigger. In other words, that's already built into the pipeline of patients. 20% of an order of magnitude more are going to need hospitalization given our current estimates. That's in the pipeline coming at you. That's not possible. That might not happen. There is a pipeline preloaded. What is this? This is something we understand a lot about slow time delays in control systems. Only now our control system for managing the outbreak is operating at regional, national, continental scales. Where because of the lag between when the need shows up at the ICU door and when the infections are growing in the population makes it very difficult for people to understand. And that's where anticipatory control, anticipatory information and action before waiting for everyone in line at the ICU door is absolutely fundamental. The fact that we have people denying in the US, a couple people recanted today. Oh, I'm sorry. As it starts to become more clear cut, or the Imperial report to the UK, they were saying crazy, they were saying bizarre stuff. And then, well, here's the thing, and it was still kind of bizarre, but it finally got them to shook up a little bit to go, oh, wait a minute. If we don't slow down the rate of illness, the growth of illness, right, we will not be able to generate, mobilize, or deploy appropriate capabilities. We will be overwhelmed.
That leads me to a question. The people who are asymptomatic do not present a load to the medical system. It is only the people who require hospitalization that we are concerned about when we're regulating the rate. So
the problem is the transmission. So the fact that what makes this particular disease particularly difficult is it has enough fatality, enough threat to human life, especially for certain populations by age and comorbidities, that you could get as much as a 5% fatality rate. That's pretty significant and way above for things like seasonal flu. So if relatively mild symptoms are asymptomatic, or people who can ride it out given their physiological state at home, right, gives you a false sense of security because there's still a transmission path unless you have a lot of isolation going on. Right?
How would we get a lot of isolation?
Well, that's all the social distancing talk that's going on of people not coming into contact, stopping large gatherings, stopping going out, etc.
That makes a lot of sense to me.
Alternative forms of work.
But why should we be isolating people who are at low risk for developing symptoms, requiring hospitalization, or requiring critical care? For example, why should we be isolating children and young adults for whom the fatality rates are minuscule and the need for intensive care is minuscule? Why not just isolate elderly and vulnerable populations? Chemotherapy patients, cancer patients, people with a history of lung disease. I can think of a number of things that would make a young person vulnerable and would absolutely warrant their isolation. But that's not everybody.
So the big thing here is transmission, though. But this is transmission. The issue is you have to reduce the transmission potential. And this is standard epidemiology. It doesn't require resilience engineering or anything. Standard epidemiology is you have to interfere and break the transmission, get it so that what we're trying to do is get to a stabilization in the occurrence of new disease that requires hospitalization. And you've got to get the total transmission rate, whether people need hospitalization or not, below 1 in the statistic they use. If it's greater than 1, that means the population of infected people is growing. Therefore, the population of people needing hospital care will be growing.
Wait a second. There's the distinction. Just because the population of infected people is growing does not mean that the population of people needing hospitalization is growing, unless there is no differentiation in those infected cases. That is, what I'm saying is, it is possible to grow infections among the demographic that is not at risk for hospitalization if you're isolating those that are, isn't it?
Well, in principle, one could try that. It won't work. And the reason it won't work is because, let me take a simpler example.
Yeah.
That's also very relevant here, which is you start running these tent evaluation or these intake mechanisms to try to figure out who's at risk of it, who needs testing, who needs what kind of care, who can go home safely, etc. You have to wear protective gear. The people have to come into the thing. It creates the possibility for transmission. Now, if you don't dispose of the various things that could be contaminated, if you don't clean the surfaces properly, if you don't do this, if you don't do that, what happens? You get
That's
transition.
a great point.
Where are you going to get? Let me give you an actual number on this, right? The current count, right? This doesn't mean it generalizes, but the current count in Italy is 8% of the cases are healthcare workers who've been infected by delivering healthcare.
Mm-hmm.
Right? So even with protective gear, by the way, what's one of the critical resources on building that readiness to respond and sustaining that response capability over time? Remember, the people who are sick for much longer than normal, right? Require intensive care much longer to recovery, is a shortage of protective gear. Ohio right now, right, pulled everything they can. They pulled in their allocation from the federal government and just stood up this afternoon and said, it's not remotely enough. Mm. We need to conserve protective gear because we also need it for the normal run of surgeries and other kinds of hospital and emergency room care for other people with severe injuries or potential injuries that would be transmittable, mm-hmm. or bloodborne infections, other mm-hmm. kinds of risky things being in a hospital that you don't want transmitted. Right? Because normal health needs and the normal risk control for those goes on. So all
I drew you a graph. Every one of these flattening the curve type graphs that we've seen always has capacity as a flat line over time. And right. What you're saying is not necessarily. When we anticipate, we can deploy, and that will increase our capacity. We can mobilize reserve resources that will further increase our capacity. And we can generate new resources. We don't know what the upper limit on that is, but the point is to move the line of capacity. Have I got that right?
Absolutely right. And this really comes across in the studies of large mass casualty events. We've done a couple that are out there. And it's also from the reports from the front lines in Italy, from some of the ICU directors. They were treating every patient who needed ICU care with ICU level care. How? By increasing their capacity to deliver, right, ICU level care. Now, there may be some triage decisions about who really needs ICU level care and when do they go in, and we may delay a little bit to wait till there's some more signs of destabilization in somebody's status. We don't know. There's reports of other kinds of decisions on the front. What comes through those reports heavily is this continual process of adaptation. The work we've done, Shauna Perry and Bob Weir's work on the emergency department as the perfect laboratory for understanding resilience and brittleness issues, right, highlights this, that they experience surges regularly. Notice the hospitals that we studied in responding to an almost 500-person burn event, which overloaded multiple hospitals' emergency rooms simultaneously and coping with that number of victims. One of the hospitals tended to operate just below their, quote, maximum surge capacity by textbook. Another one operated regularly above its normal surge capacity or nominal surge capacity. In other words, it is regularly occurring for ED departments to have processes of adaptation to generate resources to reconfigure. So our studies of that were the studies of the reconfiguration process, how they were anticipatory. When they're reactive, there's more risk of not conducting things properly for the patient. And that reconfiguration is related to all kinds of different potentially scarce resources, physical resources, space resources, equipment resources, and most notably, to me, expertise resources. Because the standard model is every patient gets the specialized knowledge and expertise as they're evaluated for their illness and risks. But when we have large numbers surging into EDs and ICUs, we reconfigure the way we deploy expertise. because there can be a shortage. There's already comments that everyone's a pulmonologist or a respiratory specialist now, regardless of what their specialty had been previously. That requires the subspecialist to work out, explain, instruct other physicians and clinical specialists how to deal with the appropriate therapies for the COVID-19 victims who need intensive care treatment. So in this case, we are reconfiguring how we bring expertise to bear to serve the large number of patients who are competing. Another thing from Italy that people should understand is it doesn't take very many critically ill people needing hospitalization and intensive care to overwhelm the system. If you look at the numbers out of Italy, right, they're in the thousands. And the ICUs are slammed there. They're also slammed because the ability, how do you sustain performance? Because the care is long run and because the rate of new infections requiring hospitalization and aggressive care keeps going up. They haven't been able to stabilize the growth and then turn the growth into a decline.
The last couple of days have been encouraging as new cases have stopped increasing in Italy. It suggests that although the total caseload is still increasing, the number of new cases has been constant the last couple or 3 days.
So that's a very important indicator. Remember back to this thing, the pipeline, right? The numbers we know is an estimate or sample of the numbers out there. And so if you can get multiple days in a row of stabilization or decline in new cases, that says there's less in the pipeline coming at me.
Yep.
And that's what you're trying to do. Reduce the patient needs that are in the pipeline on the way to your hospital or the hospitals in your region. You can look
Let me
at
see if I
ways.
can add that to the graph. I've done red and blue. In blue, we have this increasing caseload, but because we've deployed and we've mobilized new resources, we're still able to treat the exponentially increasing caseload. We've done our deploying and we've done our mobilization in anticipation of these cases. But then there comes a point at which the exponential rate of increase exceeds this, our current capacity. We must generate new resources, and we either fail to do that by failing to anticipate, or the rate at which we can generate those new resources is too slow. In red, because we did not slow the rate of transmission, we did not slow the caseload, we have exceeded saturation, and we now have cases that are unable to get the care that they need. However, if we do slow that rate of transmission, if we do bend this or flatten this caseload curve, perhaps it buys us enough time to continue to generate new resources and allocate the medical care that we need to the people who need it. Does that look right?
That looks good. And,
right.
In fact, it's related to curves we drew about emergency rooms as the natural case 15 years ago.
Yeah.
Right? So this is something we're understanding, and we need to get out there, and we need to do things to help prepare. Now, what's interesting about this case, this episode that's going on, is the scale, the temporal scale, the spatial scale. And what that means is the mobilize and generate requires more synchronization across different levels in regions and nations and societies. The examples I was giving at Ohio, where you have regional cooperation across disparate jurisdictions, where you have functional units across space and coordinating information about details of patient care so they can be ready in advance and test out different mechanisms to be ready as a surge approaches them. But you also see it. You also see and certainly in the U.S. and the U.K. examples of poor vertical coordination, where the top levels, the highest echelons in society, are slow and stale in being able to respond to the situation. in terms of investments that facilitate authorizations, funding, other kinds of things that produce the resources that will become in short supply because of the scale this will operate on and the time scale over which this will continue. And so the great example of that is the availability of protective gear for the healthcare workers, right? That undermines the ability to respond because of sustained performance limits, right? How do you, and we've already seen pictures of healthcare workers who because in part because of a shortage of protective gear, but other reasons, are just working till they drop.
Right.
And we see pictures of them collapsed.
And then they become infected, and then they're out for a month.
Or even the possibility of them being effective, and you have to pull them out. And so you're shorted your personnel, right? So can you sustain this over the weeks people need care, the weeks this is growing, and the fact that this is not an episode which will end soon. This is not an episode that will. This is an opening episode of something that has a much longer time course as a novel virus moves through the populations around the globe. Moves from more urban to more rural. This, as it crosses seasons, as initial mechanisms come into play, because we still don't have vaccines that would allow us to reduce the number of people who get sick, to reduce the severity, to target some of the mechanisms you talked about earlier around particularly vulnerable populations in an analogous way to how we try to minimize the risk to vulnerable populations from seasonal flu, even though the death rate from that is 30 times less at this stage than the novel virus. So what will that look like in the long run as it moves from a novel virus to a background part of the disease risk across the globe, right? And that process is going to take time. And it's going to take time to put in vaccines. It's going to take time to manufacture and distribute them. It's going to take time to evaluate their effectiveness. It's going to take time to be able to modify the vaccine as we see mutations and variations in the virus, because it doesn't stay stable either. That's why viruses are still around. They're very adaptive. They have a built-in capability for future adaptation. Otherwise, immune systems would have already won the rivalry. So this is the opening episode of what's going to be a much longer story. We have a lot of uncertainties about how it will unfold and what will work. But at this early stage, right, our findings and research in resilience engineering, disaster resilience, the best of it applies very well. Now the question is, can we translate that into leverage? How does this help leverage people? Well, it could help with respect to higher echelons, monitoring, recognizing when saturation is at risk, and then anticipating and finding and pushing resources towards the front lines. Mm-hmm. Protective gear being a good example of what are we doing in order to generate and mobilize the production of protective gear and distribution of that so that we have sufficient, so that we can sustain performance for the sick people and not exhaust and wipe out the caregivers. In the end, somebody needs to put up a monument to the frontline care workers for this stage around the world, because they're putting everything on the line. As we've heard from reports in Italy and other places, everything they have on the line to care for the people who need aggressive intervention.
Dave, we've covered a lot of ground. I think we've done a good job of explaining the deploy, mobilize, generate model. And I like the way that you have brought in the anticipatory paradox. If you wait for definitive proof, it's already too late, because there is a time lag between the control variables at your disposal and the state variables that you're attempting to control. The multi-scale coordination problem, the learning that has to happen across geographic scales, across hierarchical scales of governance, is also an important point that makes this a complex response to a complex problem. I think we should do this again tomorrow. I think there are more topics to bring up, but I want to give you the last word.
Let me summarize what you said, and I'll leave one lead for next time. So I want to summarize it because we've already said this in the 4 cornerstones of resilience. I mean, slightly modified over time, right? We need to anticipate, right? We need to learn without waiting for being slammed, right? And we described examples of that. We need to synchronize and coordinate over different unit functions and scales, right? And we need to build a readiness to respond and not try to create that readiness when we're in the midst of running out of capacity to respond. We need to generate it before. We need to generate the capacity to maneuver before we're completely slammed or completely saturated. Those 4 things have been around as part of the fundamental guidance, high-level, broad kinds of ways of talking about what does it mean to build a capability for resilient performance, and we see them carried out now. The teaser for next time is one of the key things, and we've seen the failure of this in many groups, at many levels, is, and this goes back to basic disaster response, emergency medicine, mass casualty, etc., is you have to be decisive. In the face of uncertainty, you have to be decisive. If you wait until evidence is clear-cut for actions to take, you have saturated, you are late, you are reactive, you're risking overwhelming, you're risking poorer outcomes, right? Effectively in this, you must be decisive. Time matters. There is you can't wait for maximal information. You have to read the signals. You have to be able to see what the trend is. It's again about rate, direction, and speed of change. And when you see that pipeline being loaded up for cases that you know you can't quite count yet, you know something's coming at you given the lag, you have to take decisive steps. And so we've seen some places be willing to do that and things go well. And some of the places that did that were ones that had previous experience with a pandemic threat from SARS, for example. Mm-hmm. And we've seen other places that rationalize previous ramp-ups of capability to previous threats of epidemic and pandemic. And we've seen them rationalize and discount it away. We don't need that. We don't need to think about it. We don't need to invest in it. We don't need to build the capability in advance.
We don't need tests. We don't need no stinking test kits. Yeah.
Right. So, or the test kits aren't actually tested.
Right.
You know, it's like, yeah, we have a plan for backup electricity. Did anybody ever test? Could you actually turn on? Right. Or we have a plan for backing up our computer. Did you actually test? Did you ever actually
Did you activate your
restore from backup? And you find that you can't restore from backup. Yes, there were backups, but none of them actually worked to restore your computer. So all of these things are out there as fundamentals. Thank you, Tom, and let's hope this series
do this again tomorrow.
To think about the leverage we can bring when crises like this occur.
Thank you, Dave. I'll talk to you again soon.